Welcome everyone. This is our first Black Maternal Health panel discussion this spring, and President Pissarro is going to open up, give some opening words to begin with. We're welcoming people.
My opening words are to thank all of you for joining us in this very important panel discussion. I want to thank Natalia Sucre, the director of our libraries, Tina Callender, reference librarian, Kristen Curry, director of development, Tina Giorgio, director of alumni marketing, for all of their efforts to make this happen. I would also like to thank the moderator of tonight's event, Professor Desi Robinson, and I'd like to welcome our four panelists, Isabel Morgan, Jade Kearney, Melissa Baxter, and Bruce McIntyre. It is a singular honor for Metropolitan College of New York to host this important discussion, and we want to thank you all for joining us. I'm now honored to introduce, and I believe he is on campus, so we'll see how this works. That's why everybody suggested I not be downstairs. Our Vice President for Academic Affairs, Humphrey Crickendale, who will say a few words. Humphrey, I don't know how you're going to do it, but.
How do I do this? He just.
Tina Callender, I think you have your video camera off. That's the Manhattan Commons.
Oops. So sorry. One moment. Welcome. Yeah, I sure do. Can't get it. It's on now. Okay.
So good evening to all of you, and thank you so much for coming to Metropolitan College to have a discussion on this most important item.
Humphrey, could you please get in front of the camera so we could see your charming face?
I don't know. I thought I was in front of
Oh,
it.
Tina can do that. Tina can figure it out.
This is the camera here. So,
Let's turn around.
Javad is here. Javad is here.
I know what to do. I need
And one is here.
Oh.
You can see the classroom.
Is this better?
There you go.
There you go.
go. So again, I want to join with the president in welcoming our visitors to Metropolitan College. I especially want to thank Dr. Melissa Barber, Jade, Bruce, and Isabel for agreeing to come and to join us here at Metropolitan College to have a conversation on this very important subject matter. In case our visitors don't know, most of the students from Metropolitan College of New York tend to be women of color, and we could not think of a more important subject matter to discuss because it is so pertinent to their daily lives. And so we are proud and we are pleased to have you here with us this afternoon and to be able to virtually have this conversation from the Bronx to New York City and places in between. We look forward to a healthy discussion. And again, on behalf of Metropolitan College of New York, thank you so much for agreeing to come to discuss this subject matter. Thank you again.
Thank you so much. Welcome again, everyone. I am just going to introduce our wonderful speakers briefly. First, I'm just going to go in alphabetical order. We have many thanks to Dr. Melissa Barber for being here. Dr. Melissa Barber is a public health researcher, born and bred in the Bronx. She completed her medical training at the Latin American School of Medicine in Havana, Cuba, and is currently one of the principal investigators of the COVID-19 Community Pesquisa Project, which seeks to document and analyze the impacts of COVID-19 on South Bronx communities. Dr. Barber is co-founder of South Bronx Unite, a community-based organization dedicated to equitable access to resources. And she is the author of 30 Days of Thanks, A Journey Toward Healing and Deliverance, which is a book that we have at the Bronx, if anyone wants to take it out. Also, many thanks to Jade Kearney for joining us. Jade is the holder of 3 master's degrees, one in intercultural, multicultural, and diversity studies from George Washington University, another in elementary education and teaching from Montclair State University, and the most recent in digital media design for learning from NYU. She is co-founder and CEO of She Matters, a digital health platform that provides Black mothers experiencing postpartum morbidities access to community, culturally competent healthcare providers, and culturally relevant resources. She Matters also offers cultural competence training to healthcare professionals to decrease systemic bias and therefore Black maternal morbidity. Also, a warm welcome to Bruce McIntyre. Mr. McIntyre is the founder of saveArose Foundation, dedicated to the memory of his partner, Amber Rose Isaac, who fell victim to birth complications in 2020 due to medical negligence. A formidable advocate for birth justice initiatives, Bruce has organized communities and stakeholders in support of legislation designed to address birthing inequities for communities of color. Bruce's mission is to dismantle racial disparities in our healthcare institutions, and he has become a sought-after teacher on racial bias in the U.S. medical system. Bruce's story and activism, as many of you may know, is powerfully featured in the 2022 documentary film, Aftershock. I'm not quite sure what happened. Is someone sharing their screen?
No.
Okay, great. Great, I don't know what that was, but anyway, many thanks to Isabel Morgan for being here. Isabel is the director of the Birth Equity Research Scholars Program for the National Birth Equity Collaborative, NEBEC. Prior to joining NEBEC, Ms. Morgan served as Reproductive Epidemiology Fellow at the CDC. Isabel is currently completing a PhD in maternal and child health and epidemiology at the University of North Carolina Gillings School of Global Public Health, where she studies the effects of structural oppression on Black maternal and reproductive health outcomes. Isabel is joining us from Barbados today. And she's also co-author of a recent series of very influential research articles that work toward a model for equitable, anti-racist, and respectful Black maternal mental health care. So a very warm welcome to all of you. I will briefly introduce our moderator tonight. We're lucky to have Professor Desi Robinson. Desi is, besides being professor at the Community Health Education Program at MCNY, she is also a health and lifestyle journalist, a doctoral candidate at Teachers College, and most recently, Mama Glow trained birth and postpartum doula. So we are in the best of hands for this discussion with Professor Robinson.
Hello there. It's so wonderful to see all of these faces. It really, really is wonderful. And they're coming from all over. And I have to give a shout out to some family and friends and colleagues who have come in. It's really wonderful to see you. We have, I think I see Wendy Cohen, who is, hey there, daughter of Audrey Cohen, the founder of our school. And so it's really a pleasure to see you, Wendy. And my cousin is here, who I trained with at Mama Glow to be a doula. And I have a niece who's on here who I'm going to be a doula for, who just shared that she is going to be having a baby. And my mother is here. And I think that this is her very first Zoom call. So I'm so happy. And I want to give a shout out to my mom, because she is a lot of inspiration around the work that I do as a doula, in sharing her birth story with me many years ago, many years ago. I know it doesn't show in my face, but that birth story began many years ago. And she talked about how alone she was when she was having me. And it never even occurred to me to ask her about what that experience was like. And so that has informed so much of my work as a birth professional. And as Dean Kirkendale said, so many of our students are women. They are women of color. And so this population is really in need of a soft place to land. You know, they're coming, and so many of our students they work. Much of our population works. So our school, Metropolitan College of New York, is such a testament to the spirit of Black and brown women and Black men who are continuing their education. And so I want to really lift them up and raise them up. I'm coming to you from New York City. I'm in Manhattan on the land of the Lenape people. And so I want to raise them up and honor the space that we are all coming together on. That is the space that I'm coming together on. And I encourage you all to look up and find out who are the Indigenous people in the spaces that you operate in. And so I want to also give a shout out to Natalia. When we started this project and this conversation around Black maternal health, it literally started as a conversation. And I said that we have the space and we have the capacity to really be a hub for Black maternal health. And MCNY is really coming together to be that space to bring the really excellent and wonderful speakers that we have on our panel today. So I want to give her a shout out, because you know, I had this wonderful sort of massive idea, and she really, and Tina Calendar as well, has been the engine around it. And so thank you very much. And so I want to start out with this idea of mental health. Like, who gets to be a person who has or doesn't have good mental health? I think it's great that we're having this conversation more and more in our society, but we still are limited in who gets to be, you know, a sufferer of mental health issues. And I think we say that oftentimes when crimes are committed, we see who gets to be, oh, that looks like mental health. But we all have got to be invested in our mental health. So I want to make sure that it's something that we all think about in terms of it being across the arc of our general health. And when we pair that with the issue of racism, you know, we really deepen that conversation. And so racism has been declared as a public health crisis. It has even been brought forth in the 117th Congress that racism is a public health crisis. So how do we address that? What does that mean in terms of what we're doing here today around mental health? Maternal mental health equity is a birth equity issue. And so several studies have consistently found that higher rates of mood and anxiety concerns among pregnant and postpartum people of color, and lower treatment access for those same populations is an issue. But the good news is that we have a fervent conversation happening here today. We have professionals, we have community health workers who are actively looking to turn the tide and stem the tide of poor Black maternal health outcomes. And so some of those pathways that are addressing racism and inequities around mental health is really rich in the field of the human resources that we have addressing justice and equity. We know that investing in Black women is the way to go. We know that investing in Black women's mental health is the way to go. We know that investing in Black women-led community-based organizations is absolutely necessary. We know that valuing, honoring, and investing in community and traditional healing and ancestral practices is absolutely important. And we know that integrating care and sharing decision-making has a direct effect on birth outcomes. And so I would like to bring in our panel right now and be able to talk about some of the ways that we can address this. So our panel discussion will echo the title of what we have been talking about, particularly around the CDC's proclamation of racism as a public health crisis. So from that perspective, and I'm going to address this question to all of our panel, and I'll just kind of go across. We'll get into some specific questions later, but I want to generally ask the entire panel, from that perspective of racism as a public health crisis, how, in your view and in your work, does mental health relate to health equity and that crisis in maternal health and infant care, Black and Brown communities, and how does it shape our understanding and our experience of birth equity and that movement? So the way that my screen is set up, I have Isabel right next to me. So I'm going to start with Isabel.
Absolutely. Well, first I want to express gratitude for being able to participate and contribute to this discussion. I truly admire the work of the other panelists, and I feel really blessed to be in their orbit in this moment and to share space with everyone who's on the call and zooming in. I also want to give thanks to the organizers and the funders for making this possible. And I just think it's incredibly insightful and powerful, really, that this initiative was born out of students and staff and community members and pulling this together as an important discussion that they knew needed to happen. So to the first part of that question, first I want to provide context around CDC's proclamation, and then I'll share some reflections about maternal mental health specifically. I don't think we can underestimate or understate the power that CDC has, as a federal agency. I mean, if we reflect on CDC's role as our federal public health agency during the COVID-19 pandemic, which is still ongoing, and providing guidance that informed mask mandates, informed how states were synthesizing data on the effectiveness of vaccinations. I think it's also important to reference a specific language that Dr. Walensky, who's the director of CDC, had released in that statement in 2021, where she asserted that racism is a serious public health threat in the context of describing racial health inequities that were being exacerbated during the COVID-19 pandemic in communities of color. But that statement was released after a flurry of other states and local jurisdictions had already declared racism as a public health crisis. Like Milwaukee County in Wisconsin, from my understanding, was the first governing board and jurisdiction that passed a resolution declaring racism a public health crisis in 2019. And that preceded many declarations that came after in the summer of 2020 of what some have called the racial reckoning. I think in addition to those shifts that we saw at the local levels, I also think about the work that reproductive justice scholars have been engaging in for decades, and even the evidence base that they have been building on the effects of structural racism specifically on pregnancy and birth outcomes, and specifically racial inequities and pregnancy and birth outcomes for Black women, Black pregnant people, Black postpartum people, and other folks of color. But with that said, CDC declaring racism a serious public health threat, I think it does add legitimacy to the work that the reproductive justice scholars have been engaging in. I think about work that CDC is doing now, the Division of Reproductive Health, around maternal mortality review committees to assess how structural racism and how discrimination are impacting maternal deaths and pregnancy-related deaths. I think about the work of other agencies like NIH, releasing funding announcements and investing in initiatives like the Improve Initiative to address racial inequities in maternal health. So now I'm shifting to the latter part and thinking about maternal mental health specifically. I think that often when we're talking about the spaces that I'm in, when we're talking about maternal health inequities broadly, it seems that we're more so focused on maternal mortality and maternal morbidity. And so this conversation is important to really drill down into how does maternal mental health and how perinatal mental health, how are those critical components of one's overall health and wellness contributing towards pregnancy-related deaths, and maternal morbidities. You know, the work that's coming out of maternal mortality review committees, which are examining these entities across states and in some cities and localities, examining records to understand what's happening. How did we get to the point where we lost a woman or a birthing person during pregnancy or as a result of pregnancy-related complications? And many of those committees are identifying actually that mental health is a leading cause of maternal deaths. But I think when we look at that data more closely, we do see some racial differences where it's a leading cause of death for white women, but hypertensive conditions and disorders are leading causes of death for Black women. And so with that, with understanding the ways in which structural racism and systems of oppression do impact Black people and Black women, right? I've been thinking about how much of our current systems are capturing or not capturing the mental health experiences of Black women, Black pregnant and Black postpartum people. And as much as I think it's important to examining what's preventing Black people from actualizing wholeness and wellness, I'm also equally invested in ideating around what those solutions are to promote overall wholeness and wellness, even in mental health. And I know that's going to be part of the discussion today.
Thank you, Isabel. Yeah, I think it's also important to see in those comorbidities in terms of like hypertension, what role does mental health play in exacerbating that in terms of stress as well? And so there are obviously some links there in terms of the comorbidities.
I wanted to hop on this because it's something that we were actually conversing about as a team today. Maternal mental health, perinatal mental health is so important in diagnosing all of these things that we're just conversing about. Diagnosing hypertension, preeclampsia, all of these things. I think we often, especially in the Western world, speak of mind and body as separate, but we all know, you know, this is science, it's scientifically backed. It's really one, right? Mind and body. And when we look at those reports coming that say that mental health is like the actual number one cause of morbidity or mortality for white women, I automatically think of what are they using to capture that information? Here at She Matters, we've created a culturally inclusive Edinburgh scale. It's not called an Edinburgh scale for us, it's a culturally inclusive maternal mental health scale. To help aid in that fight, to capture accurate information to diagnose Black mothers with peri or postnatal mood disorders. I think if there was a better tool that physicians and pediatricians had to capture what is really happening in communities of color, in particular to Black mothers, a lot of this data that we're having would be wrong, right? It would show that mental health is actually one of the leading causes of maternal morbidity, is one of the leading causes of infant morbidity. And so I really think we need to look at the tools that people are using and the science back behind those tools, but also the community component. We have a large stigma around mental health in Black communities. And I don't think the current scales that we are using makes that any easier, right? They're uncomfortable. They don't meet us where we are. They don't translate if you are Afro-Latina. They don't help decrease the anxiety around child services. They don't help decrease the anxiety around overall parenting as a Black mother. And I think we have to look at those, and we have to look at what we're using when we are approaching Black moms to get the most accurate information so that we can serve Black women better.
Thank you, Jade. Dr. Barber, do you want to chime in? What are some of the connections there for you between mental health and how it relates to health equity?
Thank you. I was just thinking about Jade Kearney and what she said, because I was actually thinking about the same thing when we talk about the whole idea of mental health and how it relates to this health equity crisis in maternal and infant care. A lot of us don't think of it from the medical perspective of being, like she said, from my medical training, I trained in Cuba. And so our approach and our framework is a very different framework in training and seeing a patient, right? So we have this model where we say patients are a biopsychosocial being, right? And anytime you don't address all of those spheres, right, of that person, then illness or wellness cannot take place. And so if I'm looking at it from a medical perspective and I'm using the framework of that social medicine, kind of preventive medicine framework, and I'm also looking at it from the lens in which I was taught of a human rights framework, right? If we're talking about human rights, we're going to say that all people are equal in rights and dignity, right? All people should have access, should have availability, should have acceptable and sufficient quality healthcare service. And then we're going to also look at a being or a person, right, in the context of whether they have other barriers, other structural and social determinants of health that are contributing to that. And so I think the approach when we look at a pregnant woman or a birthing woman is to always think of birth in a vacuum, right? Even as we talk about perinatal mental health, right? We're talking about it from that mental perspective where we're trying to separate the physiological things like perinatal depression or perinatal anxiety and, perinatal, postpartum psychosis, right? We're looking at it from that framework and we're separating that from the actual fact that she's a social being. She also has these mental components to her that her environment when she's in pregnancy mode, right, has to also be considered because she's not in a vacuum. So her environment and everything else that is within the context of who she is and her lived experience come to the table. So if this woman is living in a community where she's hearing gunshots, right, the actual issue of community violence and being exposed to that violence creates anxiety, then we have a mental health issue. If she's living in a situation where she can't afford health care, right? She doesn't have medical insurance. She can't afford the necessary care that she wants to in the process of deciding how she wants this birth to take place. That is a mental health issue. Right? She's not in a vacuum and all of these things come together. And so when we talk about the nation that we live in, most of our healthcare system does not address the fact that we are talking about systemic issues, right, that we have to address in order to talk about birth equity or birth justice or reproductive justice. We have to talk about all these other things that come into play when we're looking at maternal health, Black maternal health specifically, because we're looking at people of color who have burdens, right, or are exposed to burdens that many other people will not be exposed to. We're talking about the fact that our system also has a lack of healthcare workers that are culturally competent, right? So when our mothers are walking into the hospital, they don't have the necessary healthcare workers that look like them, share lived experiences like them. But also even in that, right, we don't have team-based care so that mothers who are walking into the hospital get the mental health screening that they need to have, right? The care that they're getting is so disjointed. So the actual fact of a mother coming in to get a mental health screening is very little to none. So that is a missed opportunity to even point out the symptoms that she may be feeling that can lead her to the resources that she needs at the clinical level or the community level. We're missing opportunities because we're not detecting them because that is not in place. So we don't talk from an integrated care system, a patient-centered care system. We're missing, right, mental health workers in the process. We're missing all of these other community resources and advocates like doulas and midwives that actually come into this process that would really allow a mother to actually walk through these processes and be informed about every step of the way. And so we are dealing with this mental health issue because there's so many things that are not being caught or detected, right? But we're also trying to isolate this mother in the pregnancy, not realizing that she has a whole environment around her that is contributing to her well-being at the point in time of her pregnancy, during her, labor, postpartum, and all the other things that are going on while she's experiencing this journey.
Woo! You said a word. If we had another panel discussion, we literally could talk about, how trauma can be transferred in utero to a fetus. Like, there's just a whole conversation around that as well. Thank you so much, Dr. Barber. I want to bring in Bruce. I want to ask you about, like, what perspective do you bring in terms of this connection between mental health and how it relates to health equity?
And thank you, women. Thank you, ladies, for speaking. You guys spoke phenomenally and so passionate. So thank you so much for your words. And firsthand with my experiences, seeing the lack of equity in care is after Amber passing away. I was shocked that there was no systems that were put in place to help people like me. And instead of offering real rehabilitation, I'm getting I'm getting these evaluations that are half-assed. They're not asking me the proper questions or properly evaluating me, but they're quick to throw drugs in my face, like Xanax and other stronger antidepressants. And I'm thinking to myself, is this really what they're doing to men in my position, in my community, and how perpetuated this cycle is and how it is becoming? And we see this cycle far too often where fathers or, people get addicted to these drugs and then they become incompetent to take care of their child. And then they have to worry about Child Protective Services showing up to their homes and taking their children away from them, and their children becoming state property. And speaking to other fathers as well, they didn't really receive any help either. And there was a gentleman that I spoke to specifically who really made me get really deeply involved in this maternal health crisis movement. I was speaking to him, trying to figure out how he was coping and what services were reaching out to him. And he was telling me he didn't have anyone. He didn't have anyone to reach out to him. He didn't have anyone to speak to. You know, I'm asking how he's coping with his loss, and you know, and how he's handling his children. And he's telling me, I'm still having a really tough time, and he has to hide it every day because as the man, as the head of the household, he has to be tough. And for his children, he has to be tough. But deep down, he's having feelings and thoughts of jumping off of the roof of his children. And that really stuck with me, and that hit me really hard. To see that men in our positions aren't really being helped, and that there's no equity in that space. There's no support groups, and luckily we found him the right type of support. We started a men's group. We all got together. We supported one another, and now he's operating a gym. He's running his own gym. He has a very close relationship with his children, and it just really comes down to that support that they have behind them. You know, I believe if we did have more equity into the space, or if we did have more safer spaces for fathers, we could lower that mental health curve, because it's shown, the data is showing that mental health issues will be in the 80 percentile for Black and Brown communities by 2030. And it may be before that. We're on the fast track right now. So, you know, I believe it's really time that we bring more equity into that space for grieving fathers. We were also supposed to have our Grieving Fathers Act passed. Governor Hochul, we got it passed, but Governor Hochul vetoed the bill, which was supposed to set to help fathers and bring equity into that space. So I think we need to be advocating for bills like that, so we can you know, keep fathers in mind.
Bruce, thank you so much. It's overwhelming to even hear about some of the residual effects of the loss, you know, of a partner. So it's probably unimaginable to even think about what that daily pain must be, and having to move forward. And so I have to thank you again for taking such a deep and personal tragedy and using it to affect change in the lives of other people. It really is amazing of you to do that, because that kind of pain renders so many other people immobile, and you are active. And so I want to stay with you for a moment, you know, and talk a little bit about some of that loss, because as you know, and we've discussed it in other meetings, the CDC data shows that 84% of pregnancy-related deaths are preventable. 84% are preventable. And so in your experience as a father and a birth equity activist, an advocate, what are some of the impacts that are happening in broader terms? You talked a lot about fathers, and maybe you can talk a little bit about the Equity Act that you brought to the state.
Yeah, of course. So as I mentioned, we're trying to we're trying to get our Grieving Fathers Act passed for unmarried fathers, because once you're unmarried, it makes it very difficult through court when you're trying to proceed with legal actions. And of course, whenever you lose somebody, you lose an income, you lose that extra support. That support that I had was Amber. Amber graduated and got her bachelor's degree in psychology, and you know, she was like a therapist to me. She was someone that I was able to confide in and turn to. So that's, and I was already dealing with, things like depression and strong anxiety. And I was dealing with that really bad, and it was Amber. Amber was the one to really help me cope and deal and understand and really treat me how to love myself. So when I lost her, I lost that completely. But I knew that I had to, I was grateful that she taught me that, because even in her passing, that was still something that I learned from her. And it's something that carried on with me throughout my work and my everyday life. And, so you lose that extra support, you lose that person that's been, in your corner the entire time. You lose a mother. She would have been a phenomenal mother. She was actually supposed to receive her master's degree in business development a month before she passed away. And, so she would have been a great community leader. She wanted to create her own extra curricular activities. So, so that she has a strong passion for the children, was very, very passionate about the children. So you lose that. Whenever, as fathers, especially when you go through this and you have to go through this system, a lot of times with Black fathers.
Why are you throwing the dirt away? Why don't you put it back?
Willa, can you mute yourself, please?
Unmute.
There you go. And when you lose somebody like that, you lose a mother, you lose that support, you lose. I've seen fathers oftentimes who have to, when they're put in a position like mine, they have to fight for their children because they're not given the rights right away to the children. The children or the child is the next of kin, which is sometimes the mother. So fathers aren't being put first, or fathers aren't being cared after or looked after in that way. We're always being put last. I would, in my specific situation, Amber passed away during the pandemic, but was being neglected before the pandemic. But during that time, I had to go through surrogates court and family court. Of course, you proceed with legal action until you get your name on the birth certificate. And what I've been seeing for a lot of Black fathers is that process has been delayed, very, very, very delayed. And so what a lot of people don't know is you have about a 2.5, 3-month window to, in a public hospital, you have a 2.5, 3-year window to bring a legal case forward. And you can't unless, of course, your name is on that birth certificate. And I didn't get my name on the birth certificate until my son turned 2 years old. I had to get my process expedited through my political, through my, some partners of mine. And they were able to expedite some of my proceedings. And here we are, my son will be 3 in April, and I still don't have my updated birth certificate. So this is what the system has been doing. They've been pushing back this process to work against families. So I've noticed that the system has been working against families rather than working for families. So this is something that we all need to be paying attention to. And of course, trying to direct fathers in the right places as well, where they can be seen and heard, and they have a safe space. I often see that fathers don't like speaking out because they don't feel like they have safe spaces. So it's very important that we get them over. You can either get them over to us at the Luxor Collective. You can reach out to us at the saveAroseFoundation.org. You can send me an email and I can add them to the group. But I believe that groups like this is very, very important. And of course, we host Fatherhood Fridays in Yonkers as well, every 4th Friday of the month, for new fathers or tenured fathers, people who are able to share wisdom amongst one another. And teach each other different parenting methods, or even just to speak about how we should show up as better support partners for for our women. I believe things like this is very important, and of course, women also getting men more involved in reproductive health and education. Oh, thank you. I'm mute.
You're on mute,
You're
Desi.
muted.
Yeah, you're on mute, Desi.
Duh. I'm so sorry. I just I wanted to say thank you so much, and I wanted you to check the chat. The chat is blowing up with all kinds of support. So I just want to direct you to the chat, and also let everyone know that we're going to put the resources in the chat as well. So upcoming meetings that we're going to have and the resources that Bruce shared and our other panelists have shared will be available to you. And so I want to jump back over to Isabel, and who is the co-director of Birth Equity Research. And so in the conversation that we're having around birthing equity, and the phrase and the sentiment, research has always been there and has always been done, and the evidence comes in. And so what comes up repeatedly, both in relation to the fact that these issues of birth, Black maternal outcomes, is really about racism and not race. And so I want you to give us a sense of how research on birth equity has developed, and what, in your view, is the research that is needed now to move forward, specifically in relation to mental health and birth equity.
Absolutely. I've seen a shift even in the past several years in framing and language, and even in funding directives around this issue, maternal health and equities. So in terms of language, we talked about this a bit before we joined the call, there's been a shift from using like racial health disparities language to using racial health inequities language. And to me, it's not just semantics, that's really acknowledging the implications of structures and policies and processes on these differences, right? Disparities is really outlining differences in health outcomes. Inequities is drawing attention to the fact that they're not innate, right? That there are systems and decisions that have been made collectively, folks in power, right? That have implications for our health outcomes. So for example, when talking about pregnancy outcomes, if we understand that and believe that it's not that Black people like have an innate predisposition to preeclampsia or obesity or whatever other condition, but we recognize and acknowledge how systems and structures and policies either help us get to birth equity, they either promote that or they hinder. I think about, going back to the reproductive justice leaders who provided a vision for us, provided this human rights framework for us around reproductive and bodily autonomy. And it's a framework that shows us how to get to justice and how we can embody humanity. And then we have reproductive justice scholars that really have done that work of trying to build out the evidence for the vision. So there's amazing RJ scholars that I really adore, like Dr. Brittany Chambers, Dr. Joy Clare-Perry, Dr. Monica McLemore, Shanita Sealy Jefferson, Karen Scott. There's so many that have expanded our knowledge about structural racism, specifically about structural oppression more broadly. They've built out research identifying proxy measures and really operationalizing what is like this larger social structural phenomena. And they built out robust sound evidence that shows the implications of structural racism on pregnancy and birth outcomes. They've done this at different geographic levels, like at the county level, at the state level, at smaller geographic units. They've looked at or developed measures across different domains like housing, education, employment, political participation. It was mentioned earlier, Dr. Barber mentioned like violence in communities. That is also incorporated into some of these measures. And we see pretty consistently the implications for pregnancy and birth outcomes. And so I think, we want to shift towards the outcomes and experiences towards these affirmative solutions, I think it really calls us to think critically about how we got here, right? Like not being intellectually dishonest, not taking a historical approach, recognizing the implications of slavery, of colonization, how we've gotten here. There's more work that's been done to show the history of J. Marion Sims, for example, and experimenting on Black women and Black people's bodies for the purposes of what we now call modern day obstetrics and gynecology. All of that has implications for how, as it was mentioned earlier, Black people not feeling comfortable, invalidated and not feeling comfortable, right? Justified, excuse me, and not feeling comfortable and seeking, healthcare. Our organization has been engaged in some work around Black maternal mental health, specifically in collaboration with Kay Matthews of the Shades of Blue Project, who's based in Houston, Texas. So if you're not familiar with Kay's work, I really want to uplift her because she truly is an expert in Black maternal perinatal mental health, and even the founder of Black Maternal Mental Health Week. So I think more people know about Black Maternal Health Week, started by Black Mamas Matter Alliance, but Kay Matthews started Black Maternal Mental Health Week that happens every year in July. We had interviewed Black perinatal mental health stakeholders, including therapists and social workers and scholars, really to synthesize barriers that their clients or patients were experiencing, or for the researchers, what were the gaps in the literature, and documenting also how Black women, pregnant and postpartum people, have navigated these systems of care, right? Like also using an asset-based approach for how folks have navigated these systems and leaned into their communities to identify sources of support. And so just to highlight some of the learnings that came out of that work with Kay Matthews, we heard that women are navigating, right, these same systems and structures for care that are the same systems and structures that have imposed and inflicted harm. So this wasn't mentioned directly, but it was implied, right? People being nervous and scared to seek out care, being nervous to be upfront about mental health challenges that they're experiencing, and fear of punitive actions, right? Like their children being taken away from them. That is a very valid concern, and that is a very real concern. Several practitioners also described how their clients experience trauma, and that could be, leading up to pregnancy or birth, or that can even be during pregnancy, childbirth, postpartum. It was said during those interviews, providers not asking for consent, like to touch patients, and just assuming that that was okay because of their role as clinician, as provider. And that can traumatize or re-traumatize a woman or a birthing person as they're navigating that experience. So from that work that we had done, the data that we had synthesized from those interviews, we identified 5 key pathways towards equitable and anti-racist maternal mental health care. And they were mentioned earlier, like investing in Black women-led community-based organizations, educating and training practitioners, right, in trauma responsive care, promoting those integrated care and shared decision-making. And of course, really uplifting ancestral wisdom, uplifting these holistic tools, midwifery care, doula care, because we have evidence that they reduce the risk of medical intervention during pregnancies. And so when I think about areas that we can expand research, I think about specific subpopulations of Black people. My dissertation research focuses on infertility in Black women. I think about folks who are navigating fertility challenges, folks who've had pregnancy loss. I think they're not often considered, in the conversation. So what are their mental health needs? How can we support them through the co-occurring experience of losing a child, right? And experiencing mental health challenges. I think about gender expansive people. We're seeing more conversation about it, but I haven't seen as much research around gender expansive people, specifically trans men, on what their specific needs are as they navigate these experiences. I think about folks who have a disability or accessibility needs. I think those are areas, so subpopulations of Black people who additional research is needed, but to the formatting of the question, there is so much research that already exists that shows us what the solutions are when we invest in Black women, when we invest in Black women-led community-based organizations, when we really focus on center Black communities.
Hallelujah. Yes. Thank you, Isabel. I want to just kind of connect that with, I'm thinking about the act that Bruce wanted to bring forth to the state. How do we, or what is a good way to create that pathway between this research that's being done and connecting it with legislative and policy change? Isabel?
Oh, I'm sorry. I thought that question was for Bruce. Can you repeat that?
Oh, no, that was for you. I was saying, because I was thinking in terms of, Bruce bringing forth the act for grieving men. How do we take all of this research, this really important data, and connect it with legislative policy change that can have a direct effect on birthing people?
I've loved the advocacy that's been coming out of the Black Maternal Health Caucus. I think that work has been amazing. We have not seen all of those pieces, those 12 bills passed. Only one of the 12 pieces of legislation have been passed. But there are a number of Black women-led organizations. There's a number of professional clinical organizations that are involved in the Black Maternal Health Caucus to translate, yes, the Black Maternal Health Momnibus package, to translate research into evidence, and also engagement to address these some of the areas that I mentioned, communities I think where we didn't address directly sort of in that first the first set of bills. So now wanting to uplift Black communities that are experiencing, families that are experiencing pregnancy loss and infertility. So that is one area where I've been very encouraged, despite the bills not passing, but seeing organizations come together and really think about how do we translate this research into evidence that is direct action and that is powerful to me.
Desi, can I jump in? I also want to mention too, just the way in which we can incorporate CBPR, so that's community-based participatory action research, and really actually bringing together, and I happen to be a CBPR fellow, but really actually tie in a lot of the concrete scientific research that we're doing, and having a lot of the institutional academic partners actually be in and with the community doing a lot of that groundwork. And community-based participatory action research is something that is very new or newer in the research field. And a lot of times people, shy away from that component of research because it takes longer. It actually involves, right, community and getting community involved. It actually involves a lot of other pieces and making sure that the community is at the center of it, and that the decision-making process is an integrated process. And so I think too, if we as a people, a community, begin to push forward for methods like community-based participatory research, we will actually start to see how the work that is concrete research is also tying to and connecting to the community-based work and moving that forward, so that we see a lot more legislation happening, but also with the integration of academia with community understanding. I always say the community has always known what we've needed. We've always had to come up with internal solutions for ourselves because the external world has never done that for us. And I speak that as a South Bronx native. I speak that as a woman of color who has been in this fight for a very long time. When it comes to community organization and activism, we have always had to come up with our own solutions. And so really being at the place where we understand the power of our voice and what it means to empower ourselves to, you know, sit with legislation. We do that at the level of choosing our legislation, right? And thinking about it from the assembly level all the way up, right? And so if we're literally in the face of our elected officials and we're telling them this is important to us, because the only thing that matters to them are votes and money. Votes and money. So we need to, as a collective community, be in their faces every day, all day, making sure that we let them know what's important to us. And if this is an issue that is important to us, not only do we have to hit the ground running and do the work, right, as a people, as a community, but we now have to start integrating these institutional systems that literally come into our community and exploit our community for that research and take it elsewhere. And so really getting to a place where we can connect that academic aspect with community work and tie it together in this methodology of community-based participatory research, so that we have the intertwining of the two collective voices coming together. It is going to empower our communities tremendously. And so I just wanted to put that out there.
Thank you, Dr. Barber. I agree. Community engagement and active participation in our electoral system it's absolutely necessary if we want to raise the issues and make them stick. Marching and meeting and having collective understanding about the work that we're doing is absolutely important, but it doesn't make the same kind of change until it is policy. And so thank you. I want to bring Jade in here. And I also want to remind folks to check the chat. It is full of links and information on issues and organizations that we have brought up, some of the professionals' information on Kay Matthews' work, Shades of Blue. So please do check the chat and scoop up all of that really important information. And so Jade, I want to bring you in based on your experience as a mother and as a health educator and an entrepreneur. I want you to chime in on what some of the most important aspects of maternal mental health for birthing people of color are, and what are some of the ways that you suggest that providers can address those issues?
Thank you again. And I'm just like thoroughly enjoying this conversation. Isabel, Bruce, Melissa, thank you guys. It's like lonely up here. So to hear you guys speak is really validating, and that'll just go right into validation. Validation is extremely important on this mommyhood journey, right? A lot of mothers don't see themselves reflected in rooms where you would be seeking mental health services, right? And so they don't feel comfortable enough to come to the forefront and talk about what they're experiencing when they're experiencing it. We interviewed over 500 moms, and most moms did not know what they were experiencing while they were experiencing it, because they weren't in those rooms to have those experiences validated. For someone to say, hey, you didn't take a shower for a week, that is not normal. You're ruminating thoughts around harming yourself or your child. While that is not a mental health crisis, it is an emergency. You understand? It's an emergency. You're suffering. You're shaming yourself for these thoughts or these experiences, and you don't have to be. I think that just based off of our history in this place, shame is heavy on us. So we'll often reach out to family members, and if you aren't active in your own mental health journey, all those cultural stigma, all that cultural stigma can be a part of the conversation. So you reach out to someone. For instance, I reached out to my mother, and the first thing she said is, we are Black women. We do not have time to have postpartum depression. You have to go back to work. You need your health insurance. So often we are forced to choose between livelihood and our sanity. It's really a shame. And so that's one thing I think we need validation from each other, to say that what we are experiencing is valid, our feelings are valid, and it is not normal to feel shame. It is not normal to suffer. And I think we have this unspoken kind of mandate around shaming and suffering in silence that I think we need to get rid of. Then we have culturally relevant resources. My co-founder who's on this call, whenever we pitch to VCs or investors, she always says there's more information around the postpartum experiences of dogs than Black women. And that is the truth. That's why I'm sitting here with Melissa and Isabel, and I'm listening to you guys be able to backing up the data, you know, with science. This is so important. This is important for me when I'm in those rooms with venture capitalists. This is important for us to get those policies passed. It's important for Bruce and other men like him to get those birth certificates and things of that nature. We have to have resources. We are different. 89% of procedures done to Black women are done without their consent. Who else is that happening to? Our data is different, and I think having the conversation with healthcare providers about those differences and them acknowledging those differences because they know. So talking about it and getting them to talk about it in those rooms. And last and importantly, not least, we have to hold healthcare professionals accountable. So as She Matters, we offer healthcare providers a culturally competent certification that they pay for. So you need to be able to better meet the needs of Black mothers. It is not for us to sit at a computer, research how to safely have a baby and tell you how to treat me. So what we do at She Matters is we have a culturally competent certification that is specifically tailored for the nuances and challenges of Black mothers navigating the healthcare system. So healthcare networks and payers and providers, they purchase the certification and their physicians take it so that when a Black woman sees the She Matters shield, she knows that she's safe. She knows there's someone in that room that cares. Because the biggest problem here to me is communication. Communication between Black women and healthcare providers and the networks. So the communication isn't happening because of all those cultural nuances, because of them not understanding cultural colloquialisms. I think Melissa said something about that earlier. If a Black woman comes to the hospital and she said, "Oh my God, I feel like the Lord brought me here. He was speaking to me." This is not a mental health emergency. And you need to be culturally competent so that you can meet her and serve her better, right? So that's not happening. But also the conversation and the communication to a Black mom that says, what you are experiencing isn't normal, go to the emergency room. What you are experiencing isn't normal, go to your healthcare provider. What you're experiencing isn't normal, this is abuse. All of that has to do with communication. So we always say here, She Matters community, culturally relevant resources, and culturally competent healthcare providers. And I say this all the time, I don't know who the participants are in this call, but white people have to be in the room because they're part of the problem.
Yes, Jade. Yes, Jade. Can we all get some snaps up for our speakers? Let's just snap it up. Like really. Like, thank you for coming here and speaking truth and directing the charge for holding power structures accountable, because that absolutely must happen. And so
Can I just add on to that?
please,
I'm sorry, fired up. So
let it rip.
I'm often in rooms with venture capitalists, and I want to speak to this from like an economic lens, right? Black women get 0.2% of the venture capital in the country, 0.2%. Marge and I were able to get $1.5 million last year we raised. And I'm in these rooms every day trying to convince white men to give me money to save Black women's lives. I always have to have an ROI, a return of investment, because our lives aren't enough. And I just want to say that here. There has to be a return of investment for an investor to give me money to say this matters. And I'm saying that because that's why these conversations matter. That's why Isabel, Melissa, and Bruce matter, because I have to get the data from Isabel and Melissa to turn it into capital so somebody can give me money so that I can return it to the community. So I want you to just think about the power structures there. These are whole systems. This is systemic racism in itself. The problem is due to systemic racism. I can't get the funding, I can't get the investment because of systemic racism, because 0.2% of Black women get venture capital. Then I can't get the funds to you and the resources to us because we don't charge Black women anything. I can't get the resources to us because there are these silos, right? There are these silos of people who have the money to distribute to us. There are silos of people who are part of the problem. And if we can't penetrate these silos and be voices in those rooms, then we start to come, we have a circle. It's just a circle of information. It's just Melissa talking to me, I'm talking to Isabel, and Isabel's talking to Bruce. There are key people missing here that we have to make come to the table and have these conversations with us. Whether it's equity, whether it's nonprofit, whether it's for-profit, it has to be done.
I want to direct you guys to the chat again. The chat's blowing up. Folks are really on fire. You all have motivated them. So because I gave my link to someone, my name is coming up, but in the chat. But I think this is Zariah Flores' comment, which she says that this is why I want to get a master's in healthcare analytics and informatics, because numbers matter. And so please continue to check the chat. And I want to offer up like a couple of just statistics that I think are really important based on what you mentioned, Jade. The average amount of time that it takes, hello, little person. The average amount of time it takes for a birthing person to return to work. I think we hear a lot of 6 weeks. How many people here, raise your hand? Here 6 weeks, right? You hear 6 weeks. The average amount of time it takes for a birthing person to return to work is 10 days. That is the average amount of time it takes for a woman or a birthing person who has just released a human being from their body to return to work. 10 days. And so, you know, when Jade mentioned earlier about having to like pull it together and move forward because we have to have insurance, we have to keep this engine going in order to survive. And so we're consistently in survival mode, which makes it almost impossible to thrive.
And I just want to add that that's where policy comes in, right? When we talk, when we talk about healthcare systems and healthcare, like the systemic racism and systemic issues, right? So, like I said, my point of reference is my training in Cuba. Do you know how much time a woman who has had birth has to take off in Cuba? She has maternity leave for a whole year. 1 whole year, paid maternity leave for a whole year, because the will of that country is that mothers and babies are important. And we're going to make sure that mothers and babies are prioritized. She doesn't have to run back to work. She doesn't have to worry about those concerns, but she has to focus on being a mother to this kid. She has to focus on getting well and getting herself back acclimated to where she needs to be. So that is a policy issue. Why is it that most mothers are going back to work in 2 weeks, 4 weeks, 6 weeks when they're not ready to, right? Usually it's an economic issue, right? And on top of that, when they are going back to work, now they have a mental health issue because they're worried about who's going to take care of this child. Right? We don't have a universal healthcare system. We don't have a universal childcare system. So we're forcing mothers back to work, right? But there's no set policies in place to guarantee that there's childcare for this child, and that all of the other contributing factors that are necessary for this kid to thrive and for this mother to thrive are in place. So just wanted to throw that out there. If we need to start thinking about policy changes and how long a mother needs to have paid maternity leave, as well as a father, right? paid maternity leave. Let's actually get those numbers to realistic numbers, right? So that people can actually focus on family and focus on being well and focus on making sure that there's the follow-up treatment for, postpartum issues that may come up, that they don't have to rush back to work or rush back to situations that are not conducive for them to thrive in community and thrive in family.
Absolutely. Thank you, Dr. Barber. I was actually just going to say, and we need federal policy to make sure that fathers have time off as well to take care of their families. It's a whole literal breakdown and rebuilding of these structures that we need in order for people to not just survive, but thrive. Another really important statistic that I wanted to bring forth is economics in terms of who Black women are. These are not just poor Black teenagers in the Mississippi Delta who are suffering poor maternal health outcomes. That is true, but also statistically, you can be a Black woman with a PhD and a husband and good insurance and do very well for yourself and still suffer the same outcomes as a poor white woman. Black women with PhDs are suffering worse outcomes than white women with GEDs.
Black women who were studying these issues, like Dr. Shalon Irving, who was a reproductive epidemiologist at CDC, who succumbed to pregnancy-related complications a few days after her daughter Soleil was born. So it is incredibly upsetting, disheartening, and those statistics are true. And it goes to show, it demonstrates that the factors that we were told would protect us, they do have some protective effect, but they're not protecting Black women. They're not. Education, income, they certainly help with allowing people to have access to certain resources, but they're not protecting us from these systems and structures, from these racist systems. So, with what, my co-panelists are sharing, I'm thinking about Dr. McLemore's retrofit reform and reimagine model. It's like, this is challenging, where we are trying to retrofit and reform the current structures, right? And we don't get to do as much time with the reimagining. Like, where does that part come in when we recognize these systems were not built for us, they're built against us? So it's like we're trying to pass Medicaid expansion policies when we recognize that this whole healthcare system is not working. But yet we need to do that because we know with Medicaid expansion, people can stay on their insurance postpartum for a longer period of time. They can it'll increase access to a healthcare provider in that postpartum period. And that's particularly important because we also know the data around 60% of pregnancy-related people transitioning, Black women transitioning during that postpartum period.
I wanted to add something. When Professor Desi, she said, is that okay if I just add something here?
Please.
You mentioned, you said, and I think we all saw the study about like the richest or Black women at the doctoral level versus poor white women, right? And I just want to step back a second and say that whole statement, that whole study is drenched in systemic racism, because it has us subconsciously thinking she went to a good school, she has a husband, she's educated, and she still died. But the reality behind that is no one should die when they are pregnant and giving birth, whether she has a partner, has a degree, or whether she's poor. And that holds true for many white women. And that is a part of the problem right there, that in our minds, and I say this because when I read the study, it happened to me, it was somewhat justified. Wow. And she's married and she's economically, I'm 7 weeks postpartum, so forgive me. I have postpartum memory loss. I had twin boys. So, and she's economically stable, and she has a master's or a doctorate, and she still died, like that right there is a part of the problem, because somewhere along the lines it's been communicated to us that Black women who don't have these things are not worthy of receiving adequate care. So once we realize that we're all part of the problem, Black healthcare professionals that are part of the system as well, that's when we can move forward. But I think that is an important part to think of, because we've all somehow made peace with that study. I'm not at peace with it, because somewhere along the lines it says the girl over here who works at Target who's not married doesn't deserve the same kind of care that the woman who is married who has a doctorate degree does. We're both Black and neither one of us are receiving the care that we deserve.
A shame. So what I'm going to do is I want to wrap up with one last question for the panel, but I wasn't sure how we were going to do the Q&A, but I would like, this is what I'm going to do, and then my colleagues can say hey or nay. What I'd like you to do is write your name in the chat if you would like to ask a question, and then I can refer to you from the chat. So does that sound good, Natalia?
Yes, and also there are people in the Commons in Manhattan. So Tina Calendar can let us know.
Great, wonderful.
Okay.
That's so great. We're like in all of these locations. I think it's amazing. The other thing I want you to do is put in the chat where you're coming from, what city and state you're in, because I want to get a feel for where we all are. So put it, okay, Brooklyn in the house, Brooklyn's in the house. So right where you're from, Bronx is in the house, New Jersey's in the house, Maryland's in the house, Chapel Hill, Queens, Mount Vernon, Philly, Manhattan, Baltimore, Jersey City, Staten Island, Shaolin. I love it. I love it. Middletown, New York. Wonderful. I know that I know my mother is in Connecticut. I don't see her putting in that in the chat. Wonderful. Thank you for coming together. Atlanta, Virginia, Connecticut. Hey, Lisa. Excellent. Shout out, shout out, shout out. So I want to just wrap up our discussion part here, but I want to give some space for our audience. We have so many people from so many places. It's so great to see how fervent this is, and everybody is giving snaps and fire and love. And so we're on fire right now. This is great. So I want to put a plan of sort of action together here. I want people to leave here with a sense of knowing that they can do something to be able to affect change within Black maternal health. And so, because this is important, even if you are not in a Black family or a Brown family, when we affect change for the people who are the most marginalized, everybody wins. Everybody does well when we think about the people who are the most marginalized. So I think it's important to understand that Black maternal health is clearly an issue that is specific to the Black community. But when we start improving systems and structures for our most marginalized, everybody is going to do well. I see you in the Poconos, Dr. Demary Bonillo Rodriguez, Ridgewood, Queens. Yes. So this is directed toward the whole panel. As we are now focused on solutions for making change, I want you to speak to one or two of the most powerful ideas or proposals or tools that you have encountered from making change within health equity. And we'll also put those things in the chat. And so if those are some specific resources, we'll put it in the chat. I want to give a shout out to Tina Giorgio. Can we give some snaps for Tina Giorgio, who is like keeping that chat going, putting in information, putting in links, making sure that you guys all leave here with all the good stuff. Yes, snaps. So let's start with Bruce. Bruce,
Hey,
give us
and,
some tools. Yes.
But I definitely wanted to leave a comment on the last conversation just for a brief moment. about how, how unsafe Black women are. Amber was insured through her mother, who worked at the hospital that she ultimately passed away at. And she worked there for 25 years out of Amber's 26 years of life. So even being insured through the hospital and having a master's degree and all of that, she still wasn't safe. But just to leave that there. I think some very important ideas is I sit on the New York State Birthing Center Association board. So I believe bringing freestanding midwifery-led birthing centers forth is very important, especially since we're seeing better birthing outcomes in other industrialized nations. And I think that practice needs to be brought back to our people. Of course, it was practically sold off, and it was written off for us and practically made inaccessible for us to practice midwifery or doula care. So in order for us to operate the birthing center that we dream of and having it freestanding, is that we have to get our CPM bills passed, our certified professional midwifery bills. And in order to, so we can have out of hospital midwives. And I think that's very important, to have them on board and have their knowledge and their wisdom. And of course, still partnering with physicians that do understand the epidemic that's at hand. But I believe if you're not high risk, you shouldn't be birthing in a hospital. I believe that you should be birthing in a birthing center. And of course, looked after doulas before, during, and after childbirth, so we can curb and preserve mental health within the Black family household. And we actually we also have the womb bus that I have partnered with Milo Flores. We go to the underserved areas of the Bronx. And these are the historically known underserved areas where we see the highest morbidity and mortality rates. And we offer access to midwives, doulas, physicians of color, chiropractors, acupuncturists, health, wellness, dance, movement. We educate on reproductive health and womb wellness. And we offer these services free to the community. And just being out in the field and engaging with the community, it's very intriguing to see even young members of the community, teenagers who aren't even thinking about childbirth, who are wanting to be wanting to learn more and be more educated on reproductive health and womb wellness. And I also sit on the Fund 2 Foundation Equity Advisory Board. And what we're working on now is we're working on bringing a midwifery program to 3 HBCU colleges, and of course making that more accessible for women of color. And I believe if we created more scholarship programs to get women of color through midwifery classes, and I believe we can bridge that gap, and we're able to have more Black midwives, and we're able to have more Black doulas. Yeah, I believe that we should bring one to MCNY. I think that would be very important if we could, or if we seen that in the foreseeable future. I believe that's very important, so we can save lives, because it is known that midwives do save lives. And it's a shame that a lot of women who are practicing to become midwives have to go to places like California or Texas or out of the country just to become midwives or study these programs, when we should have it accessible here at home. So I believe that would be a true help and big push towards better birthing outcomes.
Thank you, Bruce. Again, keep checking the chat because we're getting so much love and support in the chat. So I want to quickly wrap up with Jade to give us a couple of points of action that folks can take with them. And again, if you want to ask a question, please write your name in the chat.
I think if you're a Black mom, a point of action can be to do research. Do research when you're thinking about having a baby, when you're pregnant, do research after you have your child. Like, knowledge is actually power. Like, I really do. I created She Matters because it was something that wasn't available to me when I had my first daughter. I now have 4 kids. When I had my first daughter, it just wasn't, all the things that we offer is what I couldn't get. And then say the question one more time.
That was it. I just wanted to know what, a couple of tools that you wanted to share with
For healthcare providers.
well, just providers or things that they can do to affect change within this Black maternal health space.
I do think, in addition to what we offer to our moms, our certification. I think a culturally competent certification is extremely important. It's important for med students. It's important for residents. It's important for doctors. Like, it's not only for the protection of Black women, it's for the protection of you as an individual, right? You want to be able to serve everybody. You take an oath and you want to be able to do that confidently. And so I do think certification or diversity training is extremely important.
Thank you so much, Jade. Can I just ask that everybody make sure that they're on mute? Thank you very much. One resource that I would like to share is called the Earth app. It was created by Kimberly Seals Aller, and it is basically like Yelp for healthcare providers. That is a really important resource that will allow birthing people to be able to take a look and see what institutions are really favorable to birthing people, Black birthing people. Are they doula friendly? Do they allow you to have your team with you when you really need them? And so that's IRTH, Earth app. One other resource that I want to share is I do a lot of the work that I do as a doula through the citywide doula initiative. And so I would ask that if you know any birthing people who are on Medicaid, the partnership is through the City of New York and Medicaid, and you can get free doula care. And what is very important about that program is that the city pays doulas. That's another piece of this conversation that I think is really important. Care for doulas and support for doulas is absolutely necessary. Our birth workers, our midwives, our doulas are doing yeoman's work, and we have to make sure that they get a livable wage and that they get the kind of support for their mental health and their survival as well. Because what is basically happening is most of the work that doulas do, particularly in this city, in New York City, are women of color who are going to address issues that are affecting women of color. And so if the women of color who are doing that are not getting support and not getting the pay and not having that structural support that honors that work, then we're just creating another population of women of color who need help. And I'm gonna take it to Isabel, and we're gonna wrap it up really quickly.
Would you mind if I share? Would you mind if I share 2 more resources? I'm so sorry.
Sure, please do.
I'm so sorry. But we also have the Bridge Directory as well. The Bridge Directory, it puts you in touch with either physicians of color, OBGYNs, doctors, doulas, midwives, counselors, grief counselors, therapists. So I believe the Bridge Directory is also a huge one for if you're looking for a support person of color. And then we also have the Amber Rose Isaac Access to Home Birth Scholarship Program, and it offsets the cost of insurance premiums. So whatever insurance is unable to cover, this program covers that. And since May of 2020, we've been able to help 70 families with this program who were on government assistance. So I believe if you reach out to me at bruce.mcintyre@saveArose foundation.org, I'll be more than glad to send that information across.
Thank you, Bruce. Can you put that in the chat for us too?
Yeah, certainly.
When I hear this question, I think about what, is shifting the narrative, what's challenging the status quo, what's getting us closer to Black liberation. And then to Jade's point, how are we holding systems, people accountable? So there's the patient-reported experience measures. I know Dr. Kieran Scott is working on developing those measures, and also the research and strategy team at my organization that's led by Carmen Green is working with Johns Hopkins University Center for Health Equity to test and validate like respectful maternity care measures specific to that are patient reported. So these are being incorporated into hospitals and healthcare systems quality improvement initiatives. But that's very internal. You mentioned the Earth app, and that's another resource I was going to recommend because that's public facing.
Before we take a question, can I just mention one organization that I know that I believe is a resource, and I also just want to mention, I think, as I said before, within our communities, we always have the answer. And so the Birthing Project USA is an organization that is near and dear to my heart. I'm a member ambassador of the Birthing Project. It is the first Black national maternal infant health program in the United States. It is now a national, international program as well. And one of our models has always been Sister Friends. And Sister Friends do the job of what our aunties, our, grandmas, our cousins have always done. And what we do is we take a mom who is, pregnant for the first time, or maybe not even pregnant for the first time, but having another kid. But we usually follow them throughout their pregnancy and up until a year after the birth of their child. And so we're connecting them with the resources in the community. We're connecting them with the love, the care, the nurture that they need, because so many mothers are alone in this experience. And like you mentioned, Desi, about your mother, we want to make sure that every mother is thriving. Every mother, every Black mother is thriving. And so we are usually a part of her process and walk her through the birthing process, the labor process, and up until 1 year. And of course, we always stay with our mothers way past that 1 year mark. And we have successfully seen over 10,000 babies. The CEO and founder of the Birthing Project, Catherine Hall Trujillo, she said, I stopped counting after 10,000 babies. And so we have literally made this program not only a national program, an international program, and I'm hoping to actually start a branch of this program right here in the South Bronx. And so I just want to mention that a very active thing that we can do as not only people of color, but every color, right? We know how to support people. We know how to love on moms. We know how to nurture them. We know how to feed them. We know how to connect them to resources. And so we need to get back to doing the traditional things that we did in terms of being a village that raises a family.
Growing up, I didn't have a close relationship with my mom. I thought she was crazy. I thought she was just always yelling at us. I thought she just always had a stink attitude. I just, I didn't understand growing up. But I started to understand, getting into reproductive health work, the effect that postpartum depression weighs in on someone. My mom raised 5 kids on her own, didn't have much help. She had a low-paying job where it felt like she was working 18 out of the 24 hours of her day. So I didn't really understand what that was doing to her mentally. But once I identified that she had postpartum depression that she never dealt with, or that she never got help for, that carried along with her. And once I was able to identify that, I was able to get her the correct help. And we have a way closer bond than we've ever had. And I have a newer respect for my mother, and have a closer, stronger bond with her once I was able to identify that and able to understand and identify what she was going through.
Getting close to that time, where is Tina? Do we have any questions from the Bronx or Manhattan campuses? If not, I would like everybody to remain on mute and just give some snaps for our panel keeping their composure, for our technical people who are doing the work, trying to keep us flowing.
I have a really quick question. So,
Sure.
real fast, I know DUA is very important. I had a friend who just had delivered her baby and it was through DUA, and it was, it was a very great experience, as she mentioned. However, what about some type of services for women who cannot have any children? I know so many of us out there that does not have no children, and I'm sure it hurts them. So this is why I started Yarny Steaming. I don't know if it really helps, but for the most part, it really work with the mental health, and it helps with so many things. It helped me as well. But is there any services for women who cannot have any children, like any type of, because that's a mental disorder as well, if you think about it, a woman who cannot have any children. And I know a lot of females that's like that.
Thank you, Shanice. So if you have a business or resource that you want to share, you mentioned the yoni steaming, you can put that in the chat and you can share that with everyone. And what you can do is, if for people who would like to have children naturally, there are fertility doulas who can assist with that process of really figuring out, what may physically be going on with you, and they can offer that sort of emotional support as well, outside of a medical facility. If anyone on the panel would like to chime in on that, does anyone else have any resources that they would recommend for people who are having problems conceiving?
Absolutely. This is an important area for me. The Fertility for Colored Girls. So 2 foundations or organizations that you can look into that provide informational support, they have Fertility for Colored Girls has sort of chapters, sort of forums for Black women to meet and discuss, like have a community to discuss these challenges. So Fertility for Colored Girls is one organization. There's also grants that they provide for families that do want to proceed down the path of using assisted reproductive technologies. And then there's the Cade Foundation. Those 2 organizations that I would refer you to explore their resources.
Thank you, Isabel. So I'm going to throw it back to Natalia. I want to thank all of our panel, Bruce, Isabel, Dr. Barber. Did she have to jump? Jade? Okay. Well, we want to put it out there for Jade as well. And just say thank you so much for sharing your personal experiences, your professional wisdom, and your heart and your spirit. And I know that we are going to affect change